Okay, so welcome to Module 2. This slide, which has A, B, C, D, E on it, is just a reminder. It's not part of the module, but we're going to sometimes add things at the beginning of a module, just some extras. So A, B, C, D, E, you need to become familiar with, because this is typically the structured way of approaching someone who's either critically ill or a trauma patient who is very sick with multiple traumas. This is how we approach them. Now, it's a bit artificial because you're typically not by yourself. There's typically a team at a hospital for trauma patients or critically ill patients. So it's a bit artificial, but it helps you keep in your mind the general approach of what you should be thinking of with someone who's unstable. Okay, so whenever you get a question, or if you later in life have someone who's critically ill, it's always A, B, C, D, E. Okay, because without A, you won't make it to B, and without B, you won't make it to C, and so on. So let's just start with someone who's unstable. They've been in a car accident, and they come in and their blood pressure is very low, their heart rate is very fast, they're semi-conscious, they're they're making some sounds, they're not really making much sense though. And how do we approach this person? And the first part is airway. And airway is assessing their ability to get air into their lungs. So it's the mouth, it's the airway in the neck. Has their neck been injured? Is there swelling of the neck? Are there loose teeth in the mouth? Is there a foreign body in the mouth that's making it hard to get the air into the lungs? So airway has all to do about getting the air from the lips all the way into the lungs. And then breathing. So why do we separate that? Well, breathing has to do with the lungs themselves. So is the chest crushed? Is there a lung that's collapsed, called a pneumothorax? Is Has one of the lungs filled with massive amounts of blood? A bruised lung called a pulmonary contusion. Has one of the sides of the chest filled with fluid outside of the lung called a hemothorax, meaning there's blood filling all around the lung. Are there multiple rib fractures? Is there a section of the chest wall that's flailing? It's paradoxically moving in and out. You don't need to know all of these things right now, but it's just good to hear it once, okay? And then you'll get it later. So airway is all about getting the air in, and without that, it really doesn't matter what the lungs are doing if you can't get air in. Okay, so that's why you assess A first, and then you go to B. You listen to their lungs. You palpate their chest. You try to feel if there's multiple rib fractures. You feel if there's air under the skin, called subcutaneous emphysema, because that's an indication that likely the lung has collapsed and released air in the tissue. It kind of feels like Rice Krispies in milk, or when you press on it. So let's just say airway seems good, breathing seems good, circulation. What's their blood pressure? What's their heart rate? What is their vascular status going to their skin? Do they look pale, sweaty? Are they going into shock? And is all the blood shutting down, being shunted away from the skin, and that's why they look pale? Often in circulation, you may see external bleeding. Now, if you have external bleeding and it's obviously causing a huge problem, like a leg that's actively bleeding, you're not going to wait to get to C to address it. You're going to address it right. Someone's going to put pressure on that wound right away, and then someone else is going to deal with A and B. Okay, so it's a bit That's why I said it's a bit artificial, but it's still worthwhile knowing this. So circulation all has to do with the cardiovascular system. Okay, how is the blood pressure and heart rate and um, capillary refill in the skin? Are they perfusing well? Is the blood getting to their brain? Are they able to talk to you? Are they able to carry on some kind of conversation? Or is the blood pressure so low that they can't even converse with you? Disability is basically, it's a D basically just so it fits in, but really what it's saying is there any neurological deficit or disability? Um, is their left arm not moving? Is their right leg not moving? Um, do they have some kind of a spinal cord injury uh, to their back? So we do a quick neurological assessment to see if they're able to move their hands, move their feet, check their eyes, check the cranial nerves. That's disability. And exposure is take off all their clothes. Look at everything. Expose everything so that you see wounds that you weren't expecting. So we take off all their clothes. Often it means cutting them off, especially in the winter. And we expose their skin and looking for any other abnormalities. Okay. And E also actually stands for environment, meaning don't forget about the temperature of the room. If it's very cold in the room where this person is now lying with very little on, or they were in wet clothes, say, because they went through the ice, snowmobiling, you have to remember that the environment has to be warm. Otherwise, they're going to get cold very quickly, which can be a problem in itself. Okay. Okay, so on to module 2. We're going to talk about a number of things in this module before we really start to get into drugs and medications, which I think is a really good way to do it. Get a grounding for the understanding of how drugs are metabolized and excreted in the system, um, and understand their side effects and interactions. And of course, some geriatrics, because most people that take medications are old. They're the ones that absorb the brunt of healthcare dollars, and also, of course, they need many more medications because of all the conditions they have. Okay. Okay, so this slide, we're going to talk about what's the difference between a side effect and an adverse effect, because they sound pretty similar. Um, But an adverse effect is more significant, something that is unexpected compared to a side effect that is common to a certain drug. When even used at a proper dose, you can get a side effect. So let's get into it a bit. So an adverse effect is really an unintended effect of the drug. It's not desirable at all and can actually lead to harmful effects from the drug. Okay. Uh, so an example of that, of an adverse effect, is say an antibiotic in the group called fluoroquinolones, and you might know one. You may have heard of one called ciprofloxacin. Okay. Ciprofloxacin is an antibiotic that we use for certain bacterial infections. And we've discovered over the past 10 to 15 years that you can actually get a tendon rupture. Your Achilles tendon can actually rupture right off as a side effect from fluoroquinolones. Sorry, I used the word side effect, an adverse effect. So that's an adverse effect because not only is it serious and harmful, but it's totally unexpected and very uncommon. So that's an adverse effect. A side effect is something more predictable to the medication. So let me give you an example. Someone is needing to take, say, morphine or oxycodone, one of the one of the opioid painkillers for a broken leg, and they become constipated. Well, that's totally predictable from an opioid analgesic. Constipation is an extremely common side effect. Is it going to stop the use of the medication? No. You can easily address constipation with a laxative. So side effects don't usually stop the use of the medication necessarily, whereas adverse effects do. Okay, so think of a side effect as a relatively predictable minor effect of the drug. Adverse effect, much less predictable, um, more more potential for harm, and more unpredictability to it. Okay, so this next slide, a very nice slide on side effects. So they're predictable, can occur at the typical dose that you would use that drug at. They can be distinguished from adverse effects in terms of severity. A side effect tends to be relatively mild. Say, for example, you get a bit of diarrhea from taking amoxicillin, which is a penicillin antibiotic. Okay, does it mean you need to stop the antibiotic? Not necessarily. You may be able to adjust either the dose or just tolerate the mild diarrhea for the week. So it's a relatively mild effect compared to an adverse effect, which is much more serious and disabling to the patient. A side effect is not an allergic effect. It's not caused by the immune system compared to adverse effects, which are. So the nurse taking care of a patient often need to know, like they need to know the common side effects, right? Especially when patients are getting new prescriptions for a medication. You know, say they're getting a new medication to treat their blood pressure. Knowing the side effects of that particular drug. So that blood pressure pill might could make them dizzy. It could make them faint when they stand up too fast. It could make their heart go too slow. So those are predictable side effects of some antihypertensives. Okay. And remember that the placebo effect itself, so when large studies are being done on drugs, even if you're taking a placebo drug, meaning there's no active ingredient in it, you can still get symptoms while you're taking that drug. You may report that you had a headache one day, or maybe you'll report that you had sore muscles one day. So even a placebo effect, a placebo can have reportable side effects. Okay. Okay, so the next slide, adverse effects. So unusual or unexpected effect. So it's often not related to how the drug works, right? So for example, when we go back to ciprofloxacin and tendon rupture, that's not how ciprofloxacin kills bacteria to treat, say, a bladder infection or a kidney infection or a pneumonia. But it's an adverse effect that it can cause your tendon to rupture. Most commonly it's the Achilles tendon, but it can be a tendon, it can be the patellar tendon, and it can be other tendons in the body. So it's not related to the pharmacological action. Now, they don't occur frequently, but they're unpredictable. Who's going to get it and who's not going to get it, right? And they vary in different people. So you could have 100 people and 99% of the people don't have any significant adverse effect. And that one person gets the adverse effect to the drug. Okay, so think of adverse effects as just a more serious, more harmful than a side effect. Okay, so continuing on here with adverse effects. So serious adverse effects can result in death, congenital abnormalities, which are birth defects. So the newborn it has been born with an abnormality, can lead to life-threatening events in the patient taking the drug, such as anaphylaxis, which is a severe allergic reaction to the drug. That's an adverse effect. Or say um, you're taking an anti-inflammatory such as ibuprofen, uh, or many others in the anti-inflammatory group, the non-steroidal anti-inflammatory. They're used all the time in arthritis, headaches, pain control. Well, they can be very hard on the kidneys. They can cause nephrotoxicity, right? So that can be a potential adverse effect to those medications. And adverse effects can require significant interventions. Um, if you have anaphylaxis and having taken a medication, so say you get a dose of an antibiotic at the hospital for strep throat, as you're leaving, you start to notice that your lips are tingling, your lips are getting swollen, your fingers are getting puffy, you're getting a rash all over your body, and now you're wheezing. And you turn around and you report back to the triage, and they quickly assess that you're suffering from anaphylaxis to the antibiotic, which would require epinephrine, intramuscular epinephrine to treat it. So, in some uh, and a serious adverse effects, the nurse would need to report, right? So, if there's someone who's had an anaphylactic reaction in the hospital, um, or returns back to a clinic and tells the nurse that she's had an that they've suffered an anaphylactic reaction, that would need to be reported, so that they never see that medication again or anything similar to it. Now, if adverse effects are occurring, uh, and again, unexpectedly, but say there's a new drug that comes out in the first couple of years, there's more and more adverse effects being noted by the drug, the FDA, because there's a self-reporting system to the FDA where healthcare providers, hospitals can report unusual or concerning adverse effects to a drug. And the FDA can create a black box warning for that medication or that group of medications. So an example of that would be, say, antidepressants, right? So antidepressants are used very commonly. Studies have shown that antidepressants, when used in adolescents and children, have a potentially increased risk of suicidality in that age group. So because of that study, and because of that concern, the FDA put a black box warning around antidepressants and their use in adolescents. It doesn't mean you can't use it. It means that you have to be aware of the black box warning, and monitor it very closely. Uh, the FDA can also restrict the use of a drug in specific populations that react poorly to the drug. Okay. Uh, as well, communication of information to providers and consumers. Very common to get emails, letters about certain drugs where there's more concern about adverse effects. They can recall the product with any issues of quality or performance of the medication. And finally, if there's enough concern about a drug, or if there's new adverse effects that are suddenly becoming obvious, such as liver toxicity, kidney toxicity, the drug will just finally be removed from the market. Okay, and here is a slide on black box warnings. Um, so they're used for an assortment uh, of uh, of medications. Now, most medications do not have a black box warning, but it's a safety warning about the drug that's been given by the FDA, right? And I mentioned antidepressants and young adults and adolescents and of course children. So there's a black box warning there. You're going to come across other black box warnings on drugs. So whether it's a black box warning about not taking when you're pregnant, um, there'll be all kinds of them uh, because of adverse events that occurred in the past, and finally they put a black box warning on the medication. Okay, so we're going to go through a whole list of different types of adverse effects, right? So we're going to talk about allergies first. So allergies would be considered an adverse effect to a drug. You don't give someone a medication or a drug expecting them to have an allergic reaction. So it's not really a side effect. It's more than a side effect. Okay. And I don't think you need to necessarily memorize, okay, what's an adverse effect, what's a side effect. I think if you understand the concept, a side effect is relatively minor, pretty common, quite predictable, and doesn't necessarily change the treatment compared to an adverse effect. Much more serious, higher potential for harm, often changes the requirement for treatment, so that you may not be able to use that medication anymore. Okay. So in this case, adverse effects, we're talking about allergic adverse effects. And this is caused by the patient's own immune system that's reacting to the drug. And by far the most common adverse effects, to drugs are simply just rashes or low-grade fevers, right? So hives. Hives is a term that's the same as urticaria. We use those two terms interchangeably. And we'll come to some pictures of hives. There's all kinds of allergic drug rashes, and we'll talk about those. And you can actually get low-grade fevers from allergic reactions to drugs because there's an inflammatory response happening, right? There's an immune response. So a drug allergy uh, can go all the way from simply having some hives, also called urticaria, all the way to the other side of the spectrum, which is anaphylaxis. And anaphylaxis is the most severe form of an allergic reaction. So anaphylaxis typically means that the body is having a widespread reaction to this drug. So you're typically getting a rash, such as urticaria. You're getting airway issues. You're getting swelling of your lips, swollen tongue, a swollen airway. And remember, what do you assess first when someone's really sick? The airway. They're getting wheezing in their chest because of bronchospasm. The little bronchial tubes are getting spasmed and narrowed, so they're getting wheezing. In terms of cardiovascular, they're getting hypotensive. There's lots and lots of histamine being released by immune cells that's going into the bloodstream and causing vasodilation that leads to hypotension, so low blood pressure, fast heart rate, because the heart rate's trying to keep up with this low blood pressure to maintain it, but it can't. They can come in confused because the blood pressure is low. And one of the other systems involved in anaphylaxis is the gastrointestinal. So often people can become nauseated and start vomiting with anaphylaxis. So I'm going to give you a good way to remember anaphylaxis to anything, whether it's a food, an insect bite, or a drug. Typically you have the rash called urticaria, and I'll show you pictures, plus at least one other system. So that system could be the respiratory system, where you might have an airway issue or a breathing issue, such as wheezing, or airway swelling, or oral swelling. Or you could have, so that's one other system. Or you could have a circulation issue. So you could have urticaria plus low blood pressure, tachycardia combined. That could be anaphylaxis in the right setting with having taken a drug. Or you could have urticaria and nausea and vomiting, which is the gastrointestinal system. So after administration of a drug, if you get urticaria plus any one of those other systems, respiratory, cardiovascular, or gastrointestinal, then we would treat that as anaphylaxis, okay, with intramuscular epinephrine. And remember, anaphylaxis gives the same set of symptoms no matter what drug actually caused it. So it doesn't matter if the drug was a penicillin and you developed anaphylaxis, or the drug was a cholesterol drug and you developed anaphylaxis. The same end result is going to happen with all of those symptoms. Okay, so let's look at some drug classes or some causes of adverse effects that make this allergy group. So likely the most common group of drugs that can cause allergic adverse effects are the antibiotics. I mean, one of the reasons is because they're used so frequently, right? So penicillins, sulfa antibiotics, and many other antibiotics can often cause allergic adverse effects. Another one is radiologic contrast media. So this is often when we're doing imaging tests like a CAT scan, we have to inject dye, so radio contrast, into the vein of the patient, or sometimes we have them swallow radio contrast media to highlight parts of their bowel. But let's just say it's intravenous, and it's an iodine based contrast media. This can cause an allergic reaction. So when receiving this dye, you often get a lot of questions about previous CAT scans. Have you ever had an allergic reaction to iodine-based dyes? And the other thing that it can cause is not only can it cause an allergic reaction, but there is a connection between radio contrast dyes and kidney injury, so renal toxicity. So often we'll check someone's kidney function tests before receiving a CAT scan that requires dye. Non-steroidal anti-inflammatory drugs, again, common to develop allergic reactions. It can be as simple as a rash. Like I said, that's typically called hives or urticaria, all the way up to anaphylaxis. Okay, and these are extremely common drugs. These are all the drugs when you walk down that pharmacy aisle. Naproxen, ibuprofen. There's many anti-inflammatory medications. Cancer chemotherapy agents can cause allergic reactions, along with many other adverse effects because how toxic they are to the body. They're trying to treat a cancer or to destroy a cancer, but in the meantime, they're often destroying the patient's own cells, such as in the bone marrow, the skin, the gastrointestinal tract, and we'll talk about those in different sections. Sometimes it's just a preservative in the drug mixture. So if you're taking a pill and you have an allergic, you're taking a medication, but it's not the drug you're allergic to, it's actually the preservatives within the pill itself. Anticonvulsant medications can cause allergies. These are medications that we use to control someone's epilepsy or recurrent seizures. Drugs like phenytoin, carbamazepine, um, you'll hear valproic acid. These are anti-seizure medications. No need to memorize them now. Just hear them once so that when you hear them again in 2 or 3 months, you at least heard them once. Okay? But basically, anything under the sun can cause an allergic reaction. Any drug, any food, any insect bite can cause an allergic reaction. So there isn't a drug out there that there isn't a chance of causing an allergic reaction. Okay, and here's urticaria or hives. And this is an allergic reaction to a drug, commonly either an antibiotic, a medication, or sometimes this can be from a food the person's eaten, or an insect bite that created an urticarial rash. Because the body is is creating an immune response to the foreign antigen, and then causing this rash. And urticaria can be itchy. All it usually takes is to use an antihistamine, such as diphenhydramine, to control the itching. Sometimes we'll give people or patients a topical steroid cream to settle down the itching, but most of the time they get away with just stopping the medication and an antihistamine such as diphenhydramine. Okay, so let's look at this slide about anaphylaxis. We've spent some time on a previous slide talking about anaphylaxis. And again, anaphylaxis is the body's hyper response to a foreign antigen. So whether that was a wasp sting or a food product such as a peanut or shellfish or any one of thousands of drugs that the body has decided to react violently to. Now let's look at the effects of anaphylaxis, the most severe form of an allergy. So the skin is almost always involved with hives, which are urticaria, itching, flushed skin. Sometimes people come in looking like a tomato. Their skin is intensely flushed, and they have swelling often of their lips, of their ears. They can have some difficulty talking because their tongue is a bit swollen. Their face looks puffy. So the skin is heavily involved in anaphylaxis. The airway, often involved. The feeling of tightness in your throat. The sensation of swelling or the actual real occurrence of swelling. People sometimes come in with a hoarse throat, which is always concerning because that means that it's affecting the vocal cord area. There's swelling in a very tight part of the airway. And then the airway, if we extend it down to breathing, wheezing, chest tightness because of the bronchial tubes being tight, difficulty getting the air in and out because of the bronchoconstriction. Let's keep on going in the circle here. Gastrointestinal tract. So remember, someone who's had an injection of a drug and now has a rash, the urticaria, plus any one of these, including the gastrointestinal tract, which would be nausea, vomiting, abdominal cramping, that can be a sign of anaphylaxis, the urticaria plus the gastrointestinal tract symptoms. Cardiovascular system, we spoke about low blood pressure, fast heart rate, potentially some chest pain with that. And the central nervous system is often because the body is sensing that there's trouble, that there's low blood pressure, that the heart is racing. And that's the sympathetic nervous system turning on to try and correct the low blood pressure. And when you release epinephrine and norepinephrine in the sympathetic nervous system, you get nervousness, anxiety, right? Now, the dizziness and confusion and the tunnel vision and fainting, that's typically because the blood pressure is low, right? So you can think of some of these central nervous system effects as, well, those are occurring because the blood pressure is low, and that's why you're dizzy and confused because there's not enough blood getting to the brain. Okay, so this slide is on the concept of risk-benefit ratio. And we do this all the time in life, right? We assess the risk of something and we assess the benefit and we decide to do it or not do it. So the same with medications, right? So the FDA, for example, evaluates the risk and benefits for the whole population of a certain medication. The healthcare provider um, should be evaluating the risk and benefits for a particular patient. And then the patient themselves needs to decide what the risk and benefit of a potential medication. So there's different levels of risk benefit. FDA at a very high level, the provider at an intermediate level, and the patient themselves deciding, do I want to have this? Should I be taking this drug or not? Okay. Okay, so adverse effects. Now we're talking about teratogenicity. So we spoke about allergies a bit, the hives, urticaria, anaphylaxis, potentially caused by drugs. Now teratogenicity. So these are typically drugs or chemicals taken during pregnancy that can cause abnormal fetal development. Okay, so a high risk of birth defects are associated with certain drugs or chemicals. So these drugs are typically avoided in pregnancy because of that risk. Okay, so it would only be if the benefit outweighed the risk that we would use certain drugs in pregnancy. So let me give you an example. And this is really most important in the first trimester of pregnancy. Because in the first trimester is when all the different organ systems are developing. The cardiac system, the nervous system, the kidneys, the gastrointestinal tract, the brain. Like so, all these systems are developing in the first semester. So if you're ever asked, what's the most important trimester, in terms of avoiding drugs, it's definitely the first trimester in general, because that's the potential where a drug could affect the development of a particular organ. And remember, like, weighing the risk and benefit doesn't come with a lot of studies with pregnant women because we don't do trials on pregnant women or in children. Okay, so sometimes the safety profile of a drug in pregnancy comes with time and use of the drug over time. So, and that's why we have those pregnancy categories, right? To assess where does this drug fit in terms of safety for someone who's pregnant. But typically at all costs trying to avoid drugs in the first trimester for sure. Okay, so this is just a nice slide showing where in time during development of the fetus do these different systems start to develop. And if you look at the nervous system, 3 weeks. The heart, 3.5 weeks it starts. The eyes, 4.5 weeks. So very early on, you're getting organ development. And then really, as the trimesters progress, all the way into third trimester is really just a growth trimester, meaning the organ systems have all developed, the eyes, the ears, the heart, the lungs, the kidneys, the gastrointestinal tract, the upper and lower limbs, everything's developed. Now it just needs to grow. And that's typically the third trimester, where it's just more growth of the fetus. Now, thalidomide is an example of a teratogenic medication that was used years ago. It was highly effective for nausea and vomiting in pregnancy, which of course is a pretty common effect in pregnancy, that women get nauseated and a lot of vomiting. If it's excessive, we actually have a term for it. It's called hyperemesis gravidarum. And thalidomide was effective at helping the symptoms of this condition. Unfortunately, it had a lot of teratogenicity, causing severe abnormalities of the upper and lower limbs. So was obviously taken off the market because of these congenital effects that it caused. So here's another FDA pregnancy rating sheet. It's a bit different. This one's a bit lighthearted. Just telling you the different categories again. A being, yes, everything's fine with this, but it barely has anything in it. Air, water, folic acid. So very little would make the A list, right? I think insulin, thyroid medication, but those are natural to the body already. So you're not going to see many drugs in category A. Category B, again, it's a high confidence category. You won't see that many in category B. You'll often see some antibiotics that have been used for many years. But again, because of the lack of studies, we're hard pressed to put drugs into category B for pregnancy. Category C, there's been some questionable studies in animals, but I would say this is the most common group where you're going to see drugs that are used in pregnancy. They put them into category C because there's no really good studies that lift them into category A or B. Category D, this is shown to have some harmful effects. So this would only be used if the benefit far outweighed the risk that we already know. Okay. Category X, not to use in pregnancy, right? It's been shown to have detrimental effects in pregnancy. Category N, I don't think it's really a category. I think it was just a bit of just playing around with this slide a bit. Okay, so on to nephrotoxicity. So drug effects on the kidney. And you're going to hear this a lot going through pharmacology, that this drug can be nephrotoxic, or this drug can be cardiotoxic, meaning toxic on the heart, or this drug can be hepatotoxic, toxic on the liver, or it can be neurotoxic, toxic on the brain and the peripheral nerves. So you'll hear these terms quite a bit going forward. Nephrotoxicity is that the drug that's being taken has the potential to harm the kidneys, to harm the nephrons of the kidneys. Okay? So most drugs that we take are excreted through our kidneys. They may have been metabolized in the liver into a water-soluble metabolite, and then they're excreted into the kidneys. So the nephrons, or the renal tubules, are potentially exposed to high concentrations of a drug, and they can be injured if the drug is toxic to the nephrons. And we typically can recognize the signs of kidney injury with certain blood tests. So abnormal BUN and creatinine. So BUN is blood urea nitrogen, and creatinine is a breakdown product of muscle. And they have they have, because they're excreted from the kidney, they're typically kept in pretty tight values in intervals. So BUN is usually 6 to 20, creatinine 0.6 to 1.2. So now where does BUN come from? Blood urea nitrogen. That comes from the breakdown product of amino acids, which is the breakdown product of proteins. So because that is excreted in the kidney, if your BUN or creatinine are very elevated, it can be an indication that your kidneys are not filtering properly and they're not able to excrete these two um, blood markers. And when elevated, we make the assumption that it's the kidney that's weakened. Okay. Now, say you just ran the marathon and you became so you ran however many miles the marathon is, and you overexerted yourself. Your muscles are aching. You've become dehydrated because you didn't drink on the way. You can have a very abnormal creatinine, right? You released a lot of creatinine from the breakdown products and the breakdown of the muscles. The kidneys couldn't cope with this amount of creatinine, and you have an elevated creatinine. So does it mean that your kidneys are severely injured? No. It just means that the muscles poured so much creatinine into the bloodstream that the kidneys couldn't cope with it. But in general, let's just say that BUN and creatinine are kidney markers, okay? Because they're supposed to be filtering the BUN and creatinine. Okay, so now with any drug that's filtered from the kidney, or that's toxic to the kidney, if you become dehydrated for whatever reason, you're not drinking, you're vomiting, you have profuse diarrhea, if you become dehydrated and you're taking the drug still and it's nephrotoxic, well, it's going to be that much more concentrated in the nephrons. So dehydration can cause more toxicity to the kidneys of a particular drug that's already harmful to the kidneys. Okay, so as well, if you already have weak kidneys, point number 3, a history of renal impairment, and now you're using a nephrotoxic drug, so let's just say each kidney has about 1 million nephrons. So you got 1 million on the left, 1 million on the right, assuming you have 2 kidneys. If you have chronic renal failure and you're, say, down to 500,000 nephrons, and now you're being given a nephrotoxic drug, that's going to have a bigger hit on the kidneys. So we try to avoid nephrotoxic drugs in patients that already have weak kidneys. And then, of course, combining other drugs that are nephrotoxic. So you're on an anti-inflammatory such as ibuprofen, and then I decide, or someone decides to give you an antibiotic such as vancomycin. That's nephrotoxic. So now your kidneys are getting a double hit. Okay. Okay, so this slide is showing you some drugs that could be harmful if your kidneys have already had an injury. So common drugs to stop in acute kidney injury. Okay, so let me give you an example. That you've been really sick at home, lots of vomiting and diarrhea, you become very dehydrated, your kidneys aren't getting the proper blood supply because you're quite dehydrated, and the kidneys rely on blood supply to maintain themselves and also to filter the blood. So these are some medications that in a setting of acute kidney injury, say dehydration, that they'll have an even harder hit to the kidneys. So diuretics, for example, work on the kidneys, and they force electrolytes and and water to continue down the nephrons and out of the kidney and into the bladder. So if you're already dehydrated and the kidneys are already feeling that they've taken an injury from the dehydration, and now we add a diuretic to force them to work harder, that could be harmful to the kidneys. ACE inhibitors and ARBs are blood pressure pills. I'm not going to get into them here, but they can be harmful to the kidneys in the setting of a weak kidney already. That's due to something that like some kind of illness that's occurred. Aminoglycosides, those are antibiotics. We'll talk about them, don't worry. And they are nephrotoxic for sure. I mentioned another one called vancomycin, nephrotoxic. Metformin is a diabetic drug, very common oral anti-diabetic drug. And this, in the setting of an acutely weak kidney because of, say, some recent illness where you're not able to eat, drink, or you have profuse diarrhea, metformin can cause serious side effects or adverse effects that we're not going to get into here. So these are just examples. You don't need to memorize them. Non-steroidal anti-inflammatories. So the kidneys are very dependent on prostaglandins to do their job. What do non-steroidal anti-inflammatories inhibit? Prostaglandins. So if you think of non-steroidal anti-inflammatories, always think of their side effects and their adverse effects as the stomach lining causing ulcers, the kidneys causing nephrotoxicity and potentially kidney failure, high blood pressure, and they can be hard on the heart in congestive heart failure, partly because they're causing high blood pressure and the heart has to pump against the higher blood pressure. None of what I just said about the drugs are for you to memorize. It's just so that you get an understanding going forward, and it's going to make your life easier. Okay? Okay, so we're still talking about just concepts here. Okay, not specific drugs. Adverse effect, now we're on to neurotoxicity. Neuro meaning the brain and spinal cord. That's the central nervous system and peripheral nerves. Okay, so the peripheral nervous system and the central nervous system. So luckily the blood-brain barrier can control quite a few drugs gaining access into the brain. Not all, but quite a few. So what kind of symptoms and signs can we expect from a drug that's affecting the brain? So how can the brain respond to a drug? Well, you could have depressive symptoms. You could have anxious symptoms. You could be highly sedated. You could have behavioral changes. You could have suicidal ideations, hallucinations, and finally seizures. So every organ in the body can only respond in certain ways. And this is how the brain can warn you something bad is happening. So how does the heart warn you something bad is happening? Well, it warns you with chest pain, sweating, shortness of breath, weakness. How does the lung warn you that something bad's happening in the lung? Wheezing, coughing, short of breath. So every organ presents with its own set of symptoms and signs, and you'll get to know those as time goes on. Okay? Remember, autotoxicity, you're gonna come across drugs that are autotoxic. So toxic to the nerve leaving the ear and going to the brain. That's cranial nerve number 8. Okay? And often drugs, this is a good rule to follow, drugs that affect the kidney often affect the ear. So I mentioned aminoglycosides not long ago. They're hard on the kidney and the ear. They can cause hearing loss and ringing in your ears. Vancomycin, hard on the kidney, hard on the ears. The ears and kidneys have very similar cells when the fetus was developing. So drugs affect them in a similar way. They often harm the kidneys and the ears together. Okay, on to adverse effects of the liver. So hepatotoxicity, another very common one. Okay, so hepatitis. Hepatitis just means inflammation of the liver. If you're thinking of hepatitis from a virus, like hepatitis A or B or C, then we would call that viral hepatitis. But hepatitis by itself just means inflammation of the liver. And the liver is the major organ that metabolizes and detoxifies drugs. Okay? Hepatotoxicity or hepatitis is a common adverse effect to drugs. So if the liver is being harmed by a drug and it's becoming inflamed by a drug, it's not going to function as well. And if the liver doesn't function as well, it doesn't process chemicals as well. And one of those is bilirubin. So if bilirubin can't be processed, it backs up into the bloodstream and you become yellow. You become jaundiced. Your eyes look yellow. Your skin looks a bit yellow. And there's other effects of hepatotoxicity that we can talk about, such as, for example, the liver has specific enzymes that get released into the bloodstream when it's inflamed and the cells are dying. And we can pick those up in blood tests as well to see that the liver has developed a hepatitis or some liver injury secondary to the drug. So with certain drugs, we will actually monitor the liver with these blood tests, such as bilirubin. There's another blood test, AST, ALT. Don't worry about them. You're going to hear lots about them again. But those are just tests to see if the liver is irritated and inflamed. Okay. Now the other side of the coin is if you already have severe liver impairment, nothing to do with the drug. So say someone has cirrhosis. Well, now we're giving a drug that we're depending on the liver to break down, but it's already a severely injured and scarred liver called cirrhosis. It's not going to break down the drug very effectively. So you can get toxic levels of drug by the very fact that the liver cannot metabolize them into products that can then be excreted by the kidney. Okay, so this next slide, dermatological toxicity. We spoke about allergic skin reactions, hives and urticaria. You can also get drug rashes that don't necessarily have to be allergic, like urticaria and hives. And skin reactions are very common with drugs. You can get all kinds of skin rashes secondary to a drug, and not all of them have to be allergic. We do mention urticaria here, but there's a condition called angioedema, where you get massive swelling of the lips and the tongue. It can affect your airway. Now, could that be part of anaphylaxis? Absolutely. And that would be an allergic reaction. Can it develop by itself to certain drugs? Yes. And it's not an allergic reaction. So just don't get confused. Angioedema can occur from a drug as an allergic reaction, or just as an abnormal adverse effect to the drug. Stevens-Johnson, another severe drug rash that can occur. And we'll see some pictures of these. Photosensitivity is you've been given a drug, and of course the drug circulates throughout your whole body. And in the setting of UV light, sunlight, your skin gets a rash because of the combination of the UV light and the drug in the vascular system and in the skin itself. And that's called photosensitivity. And we often tell people, don't go out into the sun if you're taking this antibiotic. Very common one, tetracycline. That we tell people, don't go out in the sunlight a lot with tetracycline. There's a good chance you're going to get a photosensitive rash. And there's other antibiotics that can do it as well. Okay, so here's another nice picture of urticaria or hives. And if you look closely at the red areas, you can see that they're actually raised a bit. It's a bit hard to see in the picture, but the red areas are raised and the pale areas are more just flat on the skin. And we call that a wheal and flare reaction of urticaria. Okay, so the wheal and flare. So the flare is the red part, and the surrounding pale part is the wheal. So if you see the term wheal and flare, that's referring to urticaria or hives in an allergic reaction. So this is a common occurrence of rash from amoxicillin. Not typically dangerous at all, unless this rash were to be associated, remember, with one of those other systems: airway or breathing, cardiovascular, gastrointestinal, right? So always think, if it's just a rash and it's an innocent rash, such as urticaria, and allergic, no problem. If it's a rash plus breathing issues, a rash plus airway issues, or a rash plus gastrointestinal or cardiovascular, that's anaphylaxis. And that's when we use epinephrine. Okay. Okay, so here's angioedema. So it's a severe adverse effect to certain drugs. Now, sometimes this can just be, no, not just, this can be a severe allergic anaphylactic reaction. So it's the immune system getting involved here to a drug, or to anything that's been taken by mouth or injected, right? Food, drugs, insect bites, anything can cause an allergic reaction. And if it's from an allergic reaction, epinephrine, and sometimes we need to intubate, where we'll put an artificial plastic tube into someone's trachea, into the airway, before their vocal cords and their airway become so constricted that they can't breathe any longer. Okay, and sometimes that's necessary. There are some drugs that we're not going to discuss now. They're blood pressure medications. I'll just mention the group ACEs and ARBs. It doesn't matter currently, but they can cause angioedema just by themselves, not as an allergic reaction. Okay. So here's a photosensitivity rash. So somebody comes in, they get a prescription, say, for a sulfa antibiotic, and sulfa is one of the drugs that can cause a photosensitivity rash if you're out in the sun. And this is exactly what can happen. And you can see the parts of the skin here that have not been exposed to the sun. The bra strap that's going across the back and up above the shoulder has been spared the rash because it didn't see any UV light. So here is a severe adverse skin reaction to medication called Stevens-Johnson syndrome. And you're going to hear this term a lot. It's a very uncommon skin adverse effect, but it's severe, right? And we don't really know the underlying cause. We think it's partly the immune system. It's not really listed in an allergic reaction, but we think that the drug or other things that I'm going to mention trigger the immune system and cause this severe skin reaction where basically the skin is coming off in sheets. Okay. Um, so medications would be the most common cause. There are there are some viral illnesses. Herpes can sometimes trigger this reaction. Certain cancers can sometimes trigger Stevens-Johnson syndrome, but really, if I was to think of Stevens-Johnson, I'm thinking of medications. And one of the leading medications that I've already mentioned is the use of antibiotics, and in particular, the sulfa antibiotics. That you'll start to recognize as we do those modules. But many other drugs have been linked um, to Stevens-Johnson syndrome. There's a lot of the anti-seizure medications, and I'll just say the words, do not memorize them, please. Valproic acid, carbamazepine can cause it. Those are for seizures. There's an anti-gout medication called allopurinol. There's all kinds. So there's many drugs. No need to memorize. You're going to come across drugs that have this as an adverse effect. And just understand that it's a severe drug adverse effect. Not only does it affect the skin, it affects the mucous membranes in your mouth and your eyes. So your eyes are beet red, your mouth has ulcers all through it, and your skin is coming off in sheets. Okay, so definitely not a good adverse effect at all. Okay, so we're just going organ by organ here and talking about adverse effects that different drugs can cause. And you must be wondering, why are we using any of these drugs? Look at the side effects they can cause. And that's true, but we haven't really spoken about the beneficial side of the drug. So we're doing side effects and adverse effects first. So there's a benefit to using these drugs that we'll come to over time. So in terms of bone marrow suppression, there's many drugs that can affect the bone marrow. The biggest group are the chemotherapy agents for cancers. Chemotherapy agents stop rapidly dividing cells because that's how we want to kill the cancer. Well, where else do you have rapidly dividing cells in your body? The gastrointestinal tract. So you're going to get nausea, vomiting, and diarrhea from these drugs. The bone marrow is rapidly dividing, so you're going to get bone marrow suppression. The hair follicles and skin, so you're going to get skin ulcers, hair loss. So that's just a bit about chemo. I got down the chemotherapy agent discussion, but so bone marrow suppression can happen from many different drugs, but chemotherapy agents would be the most common. And so let's go on to the next topic here, aplastic anemia. So this basically means that all cell lines in the bone marrow have been knocked down, have been reduced because of the drug. So when we think of cell lines in the bone marrow, we think of the white blood cells, the red blood cells, and the platelets. Those are your 3 cell lines. So if you've been knocked down by, or if the bone marrow has been suppressed by a drug, you're going to potentially develop thrombocytopenia, anemia, and leukopenia. Okay, so low white blood cells, low red blood cells being anemia, and thrombocytopenia being low platelets. I mentioned already that it's frequently associated with anti-neoplastic or chemotherapy agents. The biggest concern initially, especially if you've knocked down your white blood cell count to a severely low level, is overwhelming infection because the patient's immunity has been so compromised. Okay, if the platelets are low, what's the risk? Well, the risk is going to be bleeding. So you could have gastrointestinal bleeding. You could be vomiting blood. You could be bleeding blood out. You could be pouring blood out of your rectum. You could bleed into your brain, which would be a hemorrhagic stroke. So low platelets, they'll definitely show on the skin, but that's relatively harmless. These little spots called petechiae, or bigger spots, bigger bruises called purpura. But it's more the internal bleeding that we would be concerned about as the platelet count goes lower and lower. And then what's the risk with anemia? Well, you're going to have weakness. You're going to potentially have falls because you're so weak. And falls can lead to a whole bunch of different issues, such as fractures, head injury, immobility, because now you're in bed after the fall. Okay, on to the next organ in terms of adverse effects, cardiotoxicity. So heart toxicity. There's some chemotherapy drugs that are direct culprits of being toxic to the heart and leading to heart failure that are used for certain cancers. And the big one, don't need to memorize, but just as an introduction, doxorubicin is a chemotherapy agent used for a number of different cancers, and it's directly toxic to the heart. Okay? And can put people into heart failure. So just take that as information right now. I know you'll come across it later. The other thing about drugs is many drugs can impact the electrical system of the heart, the conduction of electricity that you may have studied in A&P that goes from your SA node to your AV node and then into your ventricles, down the bundle of His, and then the bundle branches, and then the Purkinje fibers. Okay, so because a lot of drugs can cause problems with the electrical current in the heart, they can prolong a certain electrical interval called the QT interval. And this will make a bit more sense later. But the QT interval is a very important interval on what we call an ECG, which is an electrocardiogram. It's the readout of someone's heart rate and heart rhythm that we do all the time in emergency rooms. And if the QT interval is prolonged because of drugs, it can lead someone to go into a very dangerous rhythm called, it's a type of ventricular tachycardia called torsade de pointes. It's a French term, torsade de pointes. And it's a type of ventricular tachycardia that is preventable if we're careful by not combining many drugs that prolong the QT interval. Okay, so sometimes we have to monitor people with ECGs to see what their QT interval is to make sure it's not getting too prolonged and putting them at risk for torsade de pointes. This will make more sense later as we talk about this in more detail. Okay, well this is super convenient. Here's torsade de pointes right here. So let's look at the lower right corner of where we have a typical electrical conduction of a beat in the heart. And it starts with the P wave, which is depolarization of the atrium. And then it starts with and then it goes to a QRS, which is depolarization of the ventricles. And then there's a bit of a break, so it's a flat line there. And then you get a T wave. And T wave is repolarization of the ventricles. Okay, we'll definitely talk about this in more detail in another point, but there's an interval that we sometimes look at with many drugs that can prolong it called the QT, and it spans from Q, which is the beginning of the QRS, to the end of the T wave. And many drugs can prolong it, make this interval longer. And when you make that interval longer and longer, it puts the patient at risk for ventricular tachycardia. Why does it do that? Well, it does that because the next beat is going to come in soon. As the QT interval gets longer and longer, the T wave is going further and further out, and the next beat is going to land on the T wave. And that's dangerous. And that's what can put people into ventricular tachycardia called torsade de pointe. Okay? And many medications prolong QT. In fact, there's a whole book on QT prolonging medications. You're going to hear about some of them. Just know that combining medications that individually prolong the QT can be very dangerous for someone. And often we have to monitor their QT interval to make sure it's not getting too prolonged and putting them at risk of torsade de pointe. Okay, on to the next organ system, right? We're doing adverse effects by organ system so that you can retain it in that way. Musculoskeletal system. So the skeletal muscle and tendon toxicity. So there's drugs that can give you injuries to your muscles or to your tendons. And so if we know that we're using a drug that can cause muscle injury, we may monitor with a blood test a muscle enzyme such as CK. So a good example of this are the statin medications. You may have heard of them. Atorvastatin is an anti-lipid medication that we use for people with high cholesterol. And there's quite a few in this group. But atorvastatin would probably be the most common currently. But this group can cause some muscle breakdown. It can give people aches and pains and sore joints. And when they come back with those symptoms, we will check a CK to see if their muscle is being injured by the medication. Okay, so now to take it a step further, not only can it cause muscle pain and muscle inflammation, myositis, and release CK that we'll pick up in the bloodstream, but it can lead, in a severe form, it can lead to massive muscle breakdown, rhabdomyolysis. And when you have rhabdomyolysis and your muscles are breaking down severely, they can clog up, all these molecules can clog up your kidney and lead to kidney failure. Okay, so that would be in a severe form of a muscle reaction to a drug. Okay, muscle aches and pains would be the most common, then followed by, oh, you have an elevated CK because your muscles are inflamed by this drug. And then finally, as an extreme, rhabdomyolysis, meaning your muscles are actively breaking down severely, and now your kidneys are getting clogged, and we can see that you're developing acute kidney injury. Okay. So that's one example of muscle injury. The other one that we've spoken about is fluoroquinolones, and I gave the example of ciprofloxacin. There's a number of drugs in this group, levofloxacin, ciprofloxacin, but what's one of the really weird adverse effects? They can cause tendon rupture. Very odd. So people will come back and say, you know, my ankle, on the back of my ankle, my Achilles tendon, it really hurts. Okay, and how long have you been on Cipro for? A week? Okay. And so that they may just have tendonitis. But if taken to the extreme, they can present with complete Achilles tendon rupture. So it can span from tendonitis all the way to tendon rupture. Okay, so we've gotten through the organ systems that drugs can give adverse effects to. We've spoken about side effects. Um, my suggestion is just to think of it in terms of like concepts, not pure memorization. Just get the concepts, like, you know, what's happening in different organ systems with particular drugs. Not that you need to know any of the particular drugs now. So now we're talking about drug interactions. Okay, so it's not uncommon to be taking 2, 3, 4, 5, 6 drugs at a time. older people can easily be on 10 to 12 drugs. So let's look at what a drug that's taken can interact with. So it can interact with another drug. It can interact with the food that you're eating. It can interact with supplements that you're taking, like dietary supplements and vitamins and herbs. Um, and it can interact with medical conditions that you have. Okay, so drug-drug interactions can be significant, right? So you could be taking, say, a very powerful blood thinner like warfarin, and then you get put on an antibiotic that has serious interactions with warfarin, and it stops the warfarin from being broken down. And now you have much more blood thinning effect because the warfarin is much higher in the bloodstream, and you can run into bleeding, serious bleeding in the bowel from very thin blood. So we're always careful with checking blood interactions with medication. So we look at we check a patient's medication list, and then we see what they're being given or prescribed and see if there's any significant interactions. Food. Well, food can often, so some drugs are taken without food, some are taken with food. Some are better absorbed without food, such as, for example, iron is better absorbed without food, as an iron as a supplement or as a pill for anemia, but it's hard on the stomach. So sometimes you need to take it with food because it's so hard on your stomach. A lot of antacids. So people take antacids for upset stomach, heartburn, they ate too much. Antacids are a big culprit of interacting with other drugs. So often it's recommended that antacids not be taken with other drugs, and you'll come across that as well. Supplements, again, a big thing, kind of similar to food. Supplements can not only reduce absorption of drugs, but supplements, depending on which ones, and we'll come to some of them, supplements can interact with certain drugs and cause them to be at high levels or have a higher chance of the drug causing an adverse effect. Okay, and there's many supplements out there. Medical conditions. So somebody has weak kidneys, as we've mentioned before. So they have chronic renal failure, and we decide to put them on Advil for the next 2 weeks, which is ibuprofen. Well, ibuprofen, as mentioned before, is hard on the kidneys. So when they come back in 2 weeks, they could have significantly worsening kidney function because of the ibuprofen. Okay, so the possible effects of the drug plus any one of these four listed below it, drugs, food, supplement, or medical condition. You can have a decrease in the drug action. You could have an increase in the drug action because, say, the metabolism was affected of the drug and it was not being broken down as quickly. Or you can have an adverse effect because of a drug-drug interaction or a drug supplement interaction. You could have an adverse effect. Okay, so this slide is worth spending a bit of time on just to see that drugs don't just interact with other drugs. They can interact in the gastrointestinal system with food and have reduced absorption. Supplements can magnify the effects of drugs, so you can get adverse effects. So spend a bit of time on this slide. Okay, so drug interactions with food. Okay, so the drug interaction with food can be taking place in the gastrointestinal tract, where, say, the food is stopping the absorption um, of the drug, or it can take place in the liver or the bloodstream, where the food is stopping, say, the breakdown of a drug in the liver um, because of the food's effect on the liver. So it doesn't only have to be in the gastrointestinal tract. And here's an example. So statin drugs we were talking about, they're for high cholesterol. They do not get along with grapefruit juice. You're going to hear a lot about grapefruit juice in the next couple of semesters. Not really sure why grapefruit juice has been hit upon so hard for NCLEX and ATI, but it is. So grapefruit juice reduces the breakdown of statins in the liver. What's the problem with that? Well, you're going to get elevated levels of the statin, which could give you increased toxicity of the drug, such as muscle injury. I mentioned muscle injury because we were talking about elevated CK from statins. And statins can also cause some hepatotoxicity, some liver injury. So you don't want to be so toxic. So the advice will be not to take grapefruit juice while you're on a statin. MAOI inhibitors are old antidepressants that we will talk about in the future. Monoamine oxidase inhibitors. And there's a lot of food out there that has tyramine in it. And tyramine, when combined with MAOI inhibitors, can cause severe hypertension, like a hypertensive crisis, dangerous levels of blood pressure. So if you're on an MAOI inhibitor, you actually have to avoid tyramine-containing foods, which typically are old cured meats and old strong cheeses. There's others, and we'll get to it when we talk about that section. Warfarin, a blood thinner. It's a strong blood thinner we use for many conditions that we want to thin the blood for, like a deep vein thrombosis in your leg, or a blood clot in your lung called pulmonary embolus. And the reversal agent for warfarin is vitamin K. So if you're eating a lot of vitamin K rich foods, such as spinach, which is very high and many vegetables are high in vitamin K, you're going to reverse the effects of warfarin. You're going to thicken the blood because you're reducing the effects of the warfarin. Okay. Another example, acetaminophen. It's Tylenol. So if you're taking acetaminophen, and which can be toxic on the liver, it can give you a hepatitis if you're taking large amounts of acetaminophen, and then you add alcohol. You start consuming considerable amounts of alcohol, which also is hepatotoxic. Well, now you have two drugs that are, well, you have one drug in one food, or drink, and they're combining to cause hepatotoxicity. Okay, so food and drugs can interact not only in the gastrointestinal tract, but in your system as well, in the liver, or in the case of the MAOI inhibitors and tyramine, that would be in the systemic circulation in the brain where the antidepressants are working. Okay, and this slide is showing you two potential causes that grapefruit juice can do with certain drugs. So at the top line, you're taking a medication. You've also ingested some grapefruit juice, and there's an enzyme that's been blocked that's supposed to break down the drug that that you just took. So now you get elevated levels of drug in the bloodstream. Okay, and that would be the case in terms of the statin drugs and grapefruit juice. There's other ones as well for sure, I'm not going to list them now, but just know that you're going to hear about grapefruit juice a lot. Another potential for grapefruit juice is to actually lower the drug in the bloodstream. So you take the drug, you consume grapefruit juice, and the drug um, is now being broken down rapidly. Okay, so the grapefruit juice has inhibited the transporter of the drug that's supposed to get it to the site of action, and now the drug is exerting less effect on the body. I would say the first will be the more important one, that it's causing elevation of the drug in the body. So just understand this concept. Okay, so let's move on to the next section, which will be medication errors and ways of reducing medication errors. Okay, so medication errors, if you can imagine a large hospital or a very busy pharmacy receiving faxes and telephone calls for medications, mixing up the right doses. There's a lot of steps that can go wrong with getting the medication, the correct medication, into the correct patient, right? So there's just so many steps and different parts of the system that are involved. So it involves the physicians, the pharmacists, the nurses, and of course the patient that's going to receive the drug. So it's rare for it to be 100%. It can't be 100% error-free, but it can be significantly reduced. Because otherwise, people are really impacted by adverse drug reactions when they weren't even supposed to receive the drug in the first place. Okay, so for the most part, they are preventable. Are they 100% preventable? Probably not. So this slide is just showing you the definition of a medication error. So any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. So there's lots of potential for errors to happen when there's multiple players handling the drug. Okay, this slide I won't spend too much time on. Again, it's on medication error reporting. And also what's called sentinel event, which is an unexpected death or injury secondary to a medication. So the steps of medication administration. So when you look at these steps, it's amazing that even more errors don't occur. Okay, so there's the physician or the healthcare provider decision to administer a medication. The prescription. Well, the prescription is very dependent on a correct prescription. So does it have proper handwriting? Is it legible? Does it have the correct name of the drug, the dosing, the interval, how often the patient is taking it, and for how long the patient is taking it for? And these sometimes will just get caught either by the pharmacist and say, oh, can you just check your prescription again? Okay, so this is followed by the pharmacist gets the prescription. The pharmacist prepares the prescription. The, the medication now gets delivered back to the hospital ward. The nurse prepares the medication. So maybe it's oral, maybe it's intramuscular, maybe it's intravenous. The nurse administers the medication to the patient, and then the nurse records the administration in the patient's chart, and then of course the nurse monitors the patient's response to the medication. Okay, so there's lots and lots of steps, and you can see many of these steps involve a nurse. Uh, so nurses have to be very aware of administering medications, how they're administering them, the correct dose, and also high-risk medications. Some of them require a double check by two nurses before it's administered. Okay, so for example, insulin requires a double check before it's administered because it's considered a high-risk medication for harm. And there's other high-risk medications that you'll come across. Uh, so another one is injectable blood thinners. They're high risk if they're given uh, in the wrong dose. So they often require a double check. So this is a good slide. Right administration of uh, medications. So the right client or patient, the right medication, the right dose, the right route, the right time, meaning is it too soon for the drug to be given? Has it been 3 hours already, or is it a bit too early? The right documentation, the right client or patient education, the right for the patient to refuse the drug. Patients can totally refuse to take the drug, which is fine, as long as they're aware of the benefit of taking the drug and the downfall of not taking the medication. They're totally in their right not to take the medication. The right assessment uh, and the right evaluation. So the right assessment meaning has this patient received a proper assessment um, uh, before the drug was given and after the drug was given? Have they had a proper evaluation as well? So how do medication errors impact the healthcare system? I mean, we know for sure they're going to impact patients, right? By potential harm, potential death. Uh, Luckily, most of them don't result in that, right? So if the wrong patient gets a medication, for the most part, it doesn't cause harm. And I can remember many instances where a nurse has come extremely upset that he or she has given the incorrect medication to a patient. And it's always very upsetting, and everyone um, typically needs just to take a big breath. And when we do an assessment, and most of the time it works out fine. So, but it can definitely extend length of hospitalization if it's a serious medication error. It can increase the medical cost for patients or the hospital. And it can cause legal challenges if someone is severely harmed by a medication incorrectly. So really, we don't really have like an acceptable occurrence rate in terms of, well, we'll accept 1% medication errors, or we don't really have an acceptable rate. We just try to get it as close to zero as possible. And errors are typically looked into, not necessarily as a form of punishment, but as a form of improving the system where the medication error took place. Okay, so now remember, with any medication error, it's not a matter of documenting first and writing in the chart and going to tell someone. It's a matter of assessing the patient first. And how do you assess a patient after a medication error? ABCs first. Airway, breathing, circulation. Are they stable? So if their airway is fine, their breathing is fine, their circulation is fine after receiving a particular drug, say a blood pressure medication when they shouldn't have, well, then you've done your patient assessment, which is the most important. Of course, documentation is necessary, but it's assessing the patient first. Okay, and causes of medication errors. I won't go into all of these, but these are all definite factors. Human factors: overworked, tired staff, some inexperienced staff that are just starting, poor handwriting, big one, um, especially for doctors. Oral orders, so taking a verbal order over the phone and then trying to remember it and then going to do something else and then giving it. And so there's confusion there. Workplace factors, it's a noisy place, there's a lot going on. There's all kinds of demands on nurses and doctors and hospitals. Pharmaceutical factors, overprescribing. Some healthcare providers overprescribe. They just have too many drugs that they're prescribing. Um, Confusing ways of writing the medication. So medical nomenclature, packaging and labeling can be confusing. The vast number of potential medications that each patient takes can be unbelievable. I've counted 24 medications in one patient. So it's a drug soup sometimes. The frequency and complexity of calculations needed to prescribe, right? So you may have 10 patients. They're on complicated medications. You need to do some math calculations first. So there's a time pressure. There's other pressures being asked of you, plus you're having to administer this medication. So there's a lot of potential for errors. Most of the time it doesn't happen though. Okay, so we've spoken about high alert medications. So these are medications that have a narrow therapeutic index or a low safety margin, right? So what are the common types of harm that a medication can cause? So you could have an allergic reaction, and we've spoken about those commonly with antibiotics. You can have all kinds of electrolyte imbalances by certain medications. Um, so diuretics, for example, can drain you of potassium. Potassium, as you're going to find out, is a very important electrolyte. And when it's low or high, it can be very dangerous for the heart and lead to arrhythmias. Hypoglycemia, so low blood sugar. So insulin and oral hypoglycemics can lead to low blood sugar, which can be dangerous. Some sedatives, such as benzodiazepines. Let me name a couple for you: diazepam and lorazepam. Or opioids, such as morphine or hydromorphone. They can cause confusion or delirium. They can also cause lethargy, fatigue. They're people at risk of falling. Bradycardia and bradypnea, which is slow breathing. Again, opioids can cause slow breathing and sedatives can cause slow breathing. So if someone comes in and they've taken an overdose of a sedative or an opioid, what's the first thing you're going to do? Airway, breathing, circulation. Okay? Assess their airway, assess their breathing, assess their circulation, and get the antidote, because both of those have antidotes that we're not going to go into now, but we will later on. Some medications can lead to hypotension. Again, opioids and sedatives can lower your blood pressure and cause dangerously low blood pressure. Blood thinners, so bleeding. Blood thinners can be risky medications. Chemotherapy drugs that cause bone marrow suppression and lead to low platelets can cause bleeding. Okay, so high-risk medications. So definitely, we've listed a number here. Just get the concept that some medications are much higher risk than others, right? So if I'm injecting someone with insulin, I have to think I could make this person hypoglycemic, and that's dangerous. So that's going to be a double check drug. I'm giving someone morphine as an injection IV for their pain. If I give the wrong dose, I could make them very lethargic. I could make them breathe very slowly and have a slow heart rate. Better do a double check with that IV morphine. Blood thinners. So blood thinners, too high a dose, I could make this person bleed. Okay, so these are just things to think about in terms of higher risk. Giving someone acetaminophen or a dose of ibuprofen in general, that's not considered high risk at all, right? Or giving them their regular medication that they've been taking for the past 10 years, that's not typically high risk. Okay, so drug names and medication errors. There are so many generic drugs and brand names for these generic drugs that some of them begin to sound the same. So there's medications that have such similar sounding names but are used for absolutely different conditions that it's important to write down the generic name and sometimes even write down the brand name in brackets so that it's not confused. Okay. And it's one of the main reasons why verbal orders should be confirmed with a written before administering. And I work with many nurses that I've worked with for many years that really like to see the written order of a medication prior to administering it, especially if it's a high-risk medication, such as IV morphine or a subcutaneous dose of a blood thinner, or something that can cause potential adverse effects. They want to make sure they have the right person and the right drug. So I think that's a good habit to get into. And I think just recognizing the fact that with thousands and thousands of medications out there, trying as much as possible to use the generic name and learn the generic name, and then maybe know in brackets a brand name, but it's really the generic name that's most important to know. Use tall man letters as a method to reduce the possibility that one drug will be mistaken for another. That's a very, which is a very good idea, right? So some letters are put in capitals to make it more obvious which drug you're referring to. Drugs with narrow therapeutic index are more likely to cause serious consequences. So, a drug that the level where it's therapeutic to the level where it becomes toxic is very, very small and narrow. Well, those are potentially dangerous drugs, right? So I can name one for you here. So theophylline is a drug that we used to use, and it's still used sometimes, but you're going to hear about it for asthma and sometimes even for COPD. And it has a narrow therapeutic window. So the level where you want it to be at is very close to the toxicity range. Okay, so for those, the chance of causing a serious adverse effect or a serious side effect is high because you could overshoot the dose very easily. Another example would be an aminoglycoside antibiotic, such as gentamicin or tobramycin. And you don't need to know the names. But what, and this is partly why we do peak and trough levels of many of these drugs. So for example, we can take a theophylline drug level. We can do aminoglycoside drug levels. We can do vancomycin drug levels. So high toxicity drugs, we often have the ability to take a drug level to double check it. And then, of course, listing high alert medications on the ward or in the emergency room. The nurses are often very aware of which drugs are considered high alert medications. Okay, so we've spoken about some of this already, that certain drugs have higher rates of medication errors. So whether it's the name of the drug that sounds similar to another medication, and there's also some medication errors that are just independent of the whole system trying to keep things in a check and balance. So failure to perform the system check, forgetting a dose, administering to the wrong patient. Those are just independent errors, right? So, so as much as possible to keep the system in check and to keep errors at a minimum, we try. So the process becomes a bit protocolized, especially for high-risk medications, in terms of how they get from the prescription to the pharmacy, back to the nurse, and then administered to the patient. Okay, reporting medication errors. So definitely a medication error. The first thing you need is the patient's vital signs. I mean, it's a bit dependent on the medication, but in general, the first thing you want to do is take vital signs of the patient. And if it was, say, an error such as giving too much insulin or giving insulin to the wrong person, well, they're also going to need frequent blood sugar checks, right? So serum glucose checks, because we know what the insulin is going to do. It's going to drop their blood sugar. So it kind of depends on what the medication is as well. They also, some medications may have a reversal, an antidote, or an intervention that's required to alter the effects of the medication that was given. So that might be an option. Medication errors must be properly documented and reported, right? So this is part of any hospital system or any clinic system, that an error must be properly documented and reported. And unfortunately, sometimes that doesn't happen, but that's to the detriment of everyone, including the patient, right? So the patient has received, say, an incorrect drug. It needs to be reported by the nurse. The healthcare professional usually needs to get involved just to do an assessment, not necessarily for blame and punishment, but just to properly document that this occurred, this was an error, and that it's explained to the patient, right? The patient deserves to know that they've had a medication error. And also, errors may be reported anonymously to the FDA. I would say that would be relatively uncommon for that to happen. Okay, so here's the system for reporting a medication error, right? So every facility, definitely hospitals, will have policies and procedures in place for reporting medication errors. How the documentation should be. It should definitely just be factual about what happened, and then to include specific interventions that were done to help the patient, if an intervention was required. So say someone got a huge whopping dose of intravenous morphine, well, they may have required some oxygen administration. They may have required the reversal agent for an opioid analgesic, which is naloxone, or the brand name is Narcan. Okay, so just giving the full details of what took place. Failure to document is typically interpreted as not only negligence, but trying to cover or to hide something, which is never seen is never seen in a good light. So it's much better to explain and document. Um, and as I said before, and to talk with the patient or to talk with the healthcare professional, and then both of you talk with the patient. So it just depends on the scenario. Um, Recording all names of individuals notified of the error. So if you notified a physician or a healthcare provider of this error, and of your concern about the error, then now it's also up to them to become involved in making sure that the patient remains safe. Okay, so what are some strategies to reduce medication errors? So nurses trying to stay up to date with medications. Well, that's really important because when a medication is prescribed and you realize that it's the wrong dose or it's the wrong medication with the wrong intervals in terms of how often it's being given, then you can have a conversation with the healthcare provider and say, I'm not comfortable with this dosing of medication, or can we just talk about this medication and the dose that's being given? Okay, um, and really, this is a very important point: is not administering a medication unless you're comfortable administering the medication, and if you're not, to communicate that with the healthcare provider um, and explain why you're not comfortable. Uh, and often it just comes down to experience and initially really being very vigilant about understanding and keeping up with medications and their doses until you become um, very strong in pharmacology, which I think you will after these two courses. So I like this slide because I mean I can see this obvious rash that the patient has, but what's most interesting to me is that the healthcare provider here, the doctor, he's wearing gloves. He's probably unsure of what this rash is, so he's decided that in case it's contagious, he's gonna wear gloves. So this next slide on the strategies for reducing medication errors is it's from a commission, and uh, some of the recommendations are actually quite useful with hospital admissions and discharges. And the first one is referring to medication reconciliation, and that's for someone who's being admitted to a hospital, for example, and they're coming in with an assortment of medications prior to being admitted. Um, And those medications have to be reconciled, meaning they need to be checked to see that the patients are all on all these different medications. So say, for example, someone brings in, 10 bottles of pills, but they're only taking a few of them. Well, the first thing is you have to communicate with the patient to see which medications are you actually taking, and to check with another source. That could be the pharmacist that's dispensing the medication. That could be the health care provider's office that's prescribing the medication. So that's what medication reconciliation means. Is sources of information about the patient's medication on admission to hospital. And then communicating the complete list to the next provider that's caring for this patient. And then at discharge from hospital, um, the patient is provided with a complete list of medications, since they could have been altered, or some could have been removed, and some could have been added. Maybe they're going home with antibiotics, or they're going home with medication for their heart disease. So they get a complete list of all the medications that they're currently on and instructions on how to take them. Okay, and here's another slide on strategies for reducing medication errors. So utilizing barcoding medication scanning systems, very common in hospitals now, whether it's the unit or a ward or the emergency room. Most places are using barcoding to verify medications. Now, being an active part of the team, whether that's with the pharmacist, the healthcare provider, and being involved in the patient's direct care and which medications they're taking. Always double checking high alert medications with another nurse. So this can prevent all kinds of medication errors. And as I said before, there's a number of high alert medications that need to be double checked. The next one is having an understanding and to know the medications that are being administered, along with side effects and adverse effects, right? And to educate the patient about the medications. Talking with other healthcare teams, other healthcare members, whether it's a more senior nurse, the healthcare provider, or anyone who can provide advice about the medication. And then, of course, any questions about medication administration, or if you have a concern about a medication, then always asking and checking before administering a medication to a patient. And everybody is human, from the healthcare provider all the way to the patient that's getting the pill. So checking medications, right? Does this make sense? Does this medication make sense? Why is this teenager getting a very powerful blood thinner? That doesn't make sense. So checking it to make sure that it's the correct medication for the correct patient, right? And over time, you definitely come to trust your instincts in terms of medications and who should be getting what. And that comes with a lot of questioning. Why is this person getting this medication? What's the problem that they have? What condition do they have? So that just comes with time. I'm not going to go over this slide. It's another slide on information about medication administration. I think it makes a lot of good points, and some of them are repetitious from other slides, but that's okay too. Remember, repetition is what makes you remember and understand things, so that it's worthwhile just reading it over. Okay, so this next chapter, chapter 6, is about seniors, geriatrics, and medications, and just an overview about older people and medications. So as we get older, we develop more and more conditions, and some of us develop more conditions than others as we get into our 60s and 70s and 80s and 90s. So we develop different conditions in different parts of the body that may require multiple medications. And it's not uncommon to see an older person on many medications. And sometimes you look at the list and you wonder, well, there has to be competing medications here. How can they feel well with all these medications? So polypharmacy is the concept of really using many medications to treat one particular patient. So the use of greater than 5 medications that a patient's on regularly. And this is very common in the older population. So they go and see one healthcare provider for their sore joints and they get a medication. They go and see another healthcare provider for their abdominal pain and they may get another medication plus a laxative. They see someone for hypertension and they get a blood pressure medication to lower their blood pressure. And then it just goes on and on. Medications for their glaucoma, medications for their heart disease, medications for their breathing problems, their COPD, and so before you know it, they're on easily 7, 8, or 9 medications. And it's partly from overprescribing. It's partly from seeing different healthcare providers and they're treating their own part of the body. And it's partly from having many comorbidities, that a patient has multiple illnesses that need treatment. This definitely increases the risk of drug interactions and adverse effects when you're taking many medications at the same time. And some medications can have conflicting effects, right? So a patient may be taking a blood pressure pill that could be quite constipating. So now they need a laxative for the constipation, right? So sometimes we use a second medication just to treat the side effects of the first medication. So this definitely generates higher and higher health costs. Okay, so on the topic of polypharmacy, which is greater than 5 medications typically. So when assessing a patient, ask the patients to disclose all of their medication, whether it's whether they think it's only important to report prescription medications or not. And sometimes patients will come in just with their prescription medications and forget to include all the other medications they're taking at home. So make sure you ask them about over-the-counter medications they're taking, herbal remedies, dietary supplements, which can really add to many more pills that they're taking regularly. And some of them can interact with prescription medications that they're already on or that they're going to receive. And as mentioned before, patients often have multiple physicians or use multiple pharmacies, right? So, and each healthcare provider may not be aware of the other 4 or 5 that are also prescribing medications. So it's really up to the primary healthcare provider and the primary team, which would typically include a nurse, to look at the medications and to identify potential interactions. And, you know, I mean, this can happen to patients in any age group, but by far this is a common scenario with older people. And so excessive medication use can lead to very common symptoms in older people because many medications are sedating. Many medications are constipating. So older patients can come in with a multitude of side effects and adverse effects because of the long list of medications they're on. And sometimes we forget to think about the drugs as the cause of their symptoms. And definitely one of the most concerning trends that we're seeing are causing confusion and falls in elderly people that are related to medications such as sedatives, sleeping pills, and opioid analgesics for pain control. The other question to try and decipher or ask the patients or family is compliance with medications. As we get older, we start to forget. It's very difficult to take a medication 3 or 4 times a day. You may not be seeing the benefit of the medication on a daily basis. So it's just difficult to remember to take all these different medications. And that's why pharmacists have come up with blister packs or dose set, little pill bottles, little pill packages for the week so that patients remember to take their medication. So what about physiological changes of aging? And This has an impact on medications because um, when medications are given, but our physiology is changing, the drugs can have a bigger effect, right? So let's just look at some physiological changes. So what about the skin? So as we get older, the skin gets much thinner. It's not as elastic anymore. It easily tears, bruises, and there's just not as much soft tissue padding with it. What about our eyes? So we tend to, a lot of older people have chronic glaucoma, which can reduce vision. A lot of older people haven't had their eyes checked for years, and they don't have optimum vision. Their visual acuity is gradually declining. They may have a condition called macular degeneration, which is in the central part of the vision. Um, on the uh, on the retina, there's a part called the fovea where the central vision hits, and macular degeneration damages that area. It damages the macula and the fovea. So that can cause reduced vision, which can be a problem with walking, reading, balance, all kinds of issues. Cardiovascular. They don't have the same cardiovascular um, strength anymore. So they can't walk as far. They can't do stairs as much because of their cardiovascular fitness. They tend to have high blood pressure, especially systolic hypertension. So the top number is elevated. So, um, so a lot of old people have systolic hypertension. The lungs are more stiff. They don't expand as easily. They don't exchange oxygen as well anymore. So older people will get short of breath more easily. Um, Central nervous system. There's gradual cerebral atrophy. The brain gradually shrinks with aging. Um, and that can affect balance systems. That can affect cognition. So cognition, like thinking. You might have um, early onset of dementia, or you may have dementia. The gastrointestinal tract tends to be slower. You're much more prone to constipation. You don't absorb foods as rapidly as you used to. Renal function tends to be declined or declining. You don't have the same reserve of your kidney function. So drugs can impact your kidneys when you're older, much more than when you're younger. Okay. Your hearing is often reduced. Your vision is often reduced. Genitourinary, you can have, well, older men can have difficulty getting their urine out because of an enlarged prostate. Older women can have incontinence issues where they're unable to hold their urine, and they're constantly leaking urine through the day, whether they're bending over or coughing. Um, the endocrine system isn't as robust. So the pancreas doesn't necessarily control blood sugars as well anymore. The thyroid gland isn't functioning as well. So all the different glands in the body are not as robust. Musculoskeletal. Older people often have osteoarthritis, which is basically a wear and tear arthritis of the joints. They tend to have muscle atrophy and muscle thinning because they're less active. So they have joint disease, osteoarthritis. They have weaker muscles. They have deconditioned muscles typically. Psychological and social. They tend to be more isolated. They're obviously retired. They don't have as big a circle of friends, so they're more prone to depressive illnesses, and their chronic conditions can put them at risk for for depression. And older people definitely have a declining immune system. They're more prone to infection, um, and when infection, um, when they do get an infection, such as a pneumonia, they're much less able to clear the pneumonia and recover. So there's many physiological changes occurring with aging. Another one is the liver. You know, the liver isn't able to metabolize drugs as well anymore. It doesn't have the same strength. So metabolizing drugs is not as strong. Clearing drugs from the kidney is not as strong. So we have to think of that when we're giving older patients medications, but at the same doses that we're giving younger patients. And it can affect them with much more strength. So sometimes we have to reduce dosages in older patients. In fact, often we have to reduce dosages. Okay, so this is just another slide on physiological changes in the elderly. We spoke about reduced cardiac output. So that's the amount of blood that the heart pumps out per minute, and that's reduced in older people. Blood pressure tends to be increased in older people. They develop atherosclerosis, which is the plaque formation within arteries around the body, such as the coronary arteries of the heart or the cerebral arteries of the brain, and that can lead to, in the example of the heart, that can lead to heart attacks or angina. In the brain, blockages there in the arteries can lead to a stroke. The lungs we spoke about already in terms of impaired gas exchange. Creatinine clearance is a very accurate measurement of someone's ability or someone's strength of their kidneys. How, how strong is their clearing ability of metabolites? That's called creatinine clearance. And we'll talk more about creatinine clearance in another module, okay? But if you think of creatinine clearance as how strong is this person's kidney in terms of filtering strength? Slowing of the gastrointestinal system, um, thinning of the stomach lining. That's called atrophic gastritis. Altered hepatic drug metabolism. We spoke about that on the other slide. Gradual elevation of blood sugar because of a gradual weakening of the pancreas. Osteoporosis is thinning of the bones, right? So the bones are gradually getting thinner, so very minor injuries can potentially break a wrist or a hip, such as if you just have a minor fall. Okay, and we spoke about the skin and how it's thinning of the skin and loss of collagen and elastin. Lean body mass, which is your muscles, declines with age. Degenerative osteoarthritic joints with loss of muscle mass can lead to reduced ability of people to walk and do their activities of daily living. And we spoke about there's the liver function again, liver function decline, and that of course plays into reduced ability to metabolize drugs. Okay, this next slide is really just a term that you're going to hear used a lot, and it's even more common in older people, orthostatic hypotension. So if you look at the slide to the right, um, really what we're testing is what is your blood pressure when you're lying flat in bed, and then we get you to sit up on the side of the bed, and then we get you to stand up to see if at any of those positions, from lying to standing, your blood pressure falls. Okay? And so why do we care about this? And the main reason is patients come in complaining of, when I stand up, I feel dizzy, or I feel lightheaded, or I feel like I'm going to fall over. So one of the things we want to check is to see if they have orthostatic hypotension, meaning that when they stand up, gravity has an effect, and their heart isn't quite able to keep up with gravity and maintain blood pressure to the brain for the first 5 to 10 seconds. So they get dizzy and lightheaded, and that's always a risk for falling in old people. And this is a very common problem in old people because we treat them with many medications to control their blood pressure, because a lot of old people have hypertension. But those same medications give them orthostatic hypotension when they get up too quickly. And that can lead to injuries and falls. So when an older person comes in and describes this symptom of, well, when I stand up, I just feel so dizzy and weak and I'm going to fall over, we definitely look at their medications to see if any of them can potentially drop or reduce their blood pressure, especially ones, and then we'll check an orthostatic blood pressure, meaning the nurse will check them when they're lying flat, check the blood pressure when they're sitting up, and check the blood pressure when they're standing up. And if there's significant differences between those positions, then we'll be concerned about orthostatic hypotension, and we may have to adjust their medications to try and prevent this symptom, and also prevent the condition of orthostatic hypotension. So many blood pressure medications can do this, especially when you're first starting them. They can have significant hypotensive effects, especially, remember, in old people who happen to be very sensitive to medications. Okay, so what about adherence, which is really another word for compliance, like taking. Compliance is a term that we use. Maybe it's not as popular a word, so adherence, but compliance or adherence means, how are you at taking your medications reliably? So adherence and drug mistakes in the older adult. So what are some of the potential issues? Well, visual issues with actually even seeing the bottle. There could be functional issues with even trying to open the bottle. If you have severe osteoarthritis or rheumatoid arthritis of your hands, very difficult to open a bottle. Cognitive dysfunction, to remember the bottle, or remember even that you need to take a pill. So if you have Alzheimer's disease or some form of dementia, you may not even remember that you're taking a medication, let alone how many you're taking. And then, of course, hearing impairments initially upon getting advice from the hospital, from the healthcare provider, from the nurse in terms of the directions on taking the pills. So, I mean, so this next slide is on adherence and drug mistakes in older patients. Some of it actually applies to younger patients as well. So you need to be able to afford the medication. That applies to many younger patients too. Believing that the medication has efficacy, that it's going to actually be able to treat the condition that you have. And that needs to be a discussion between the healthcare provider, the nurse, and the patient in terms of helping them understand the risk-benefit of the medication. Appropriately self-administering the medication. Since the vast majority of medications, the patient is going to be taking themselves. Adjusting to lifestyle changes accordingly. So there's some medications that can make you feel a bit more tired. There's some medications that can slow down your heart rate, and you won't be able to quite do the same things as you used to. There's some medications that after you take them, you may need to be near a washroom, such as a diuretic, and you may not, you may not want to do that. So that's important. So adjusting to the lifestyle changes, and also reporting side effects and adverse effects, because people will stop taking their medication if they continue to have even minor side effects or more significant effects, because a lot of medications are for chronic conditions that you're taking for life, such as for hypertension, for Parkinson's disease, which is a neurological condition. There's medications for Alzheimer's disease, which aren't very effective, but they're still available. So there's many medications that are taken for the rest of someone's life. Uh, so they really, in order to adhere to a daily regimen of pills, a lot of these, the patient has to be able uh, to be able to not only afford but understand and believe that the medication is helpful, plus all the other bullet points that we discussed. Okay, so now the other side of the coin. So the provider needs to spend some time to provide some information about the medication and the condition that's being treated. So giving someone a medication that they're potentially taking for months or years or for the rest of their life without proper information um, and expectations isn't setting them up for success, right? So now, what about the nurse's role? So providing the spouse or a caregiver with proper information about the medication, and how it's given, what side effects to look out for, how frequently should they take it, what might they have to adjust in terms of their lifestyle, such as their diet, or when they should be taking the medication, and the monitoring of the medication as well. So they may need to have follow-ups for their medication, to discuss how it's helping their symptoms or to discuss what side effects they're developing. What about medication mistakes in elderly people? So there can be overuse, underuse, or erratic use. So you can imagine all these bottles in front of an older person that has some cognitive issues or is confused about all his medications because every second month he seems to be getting different medications. He may be taking a completely inappropriate dose, whether it's too much of the medication, too little of the medication, or just not regular use, so erratic use of the medication. And overuse of the medication could be unintentional, just through confusion and just too many pills to manage, or it might be deliberate. Older patients are one of the age groups with high risk of depression and suicidality, so suicidal thoughts, and they're in a high risk category for loneliness and social isolation. Okay. Um, some older patients may just self-adjust the dose. I often hear patients telling me about how they adjust their arthritis medications, their blood pressure pills, their heart pills, depending on how they feel that day. Some people just can't afford their medication, so they're trying to make the pills last longer by breaking them in half or in a quarter. And these aren't always reported. Sometimes when people bring in all their pills to the hospital, it's obvious that some pill bottles are empty and some are full. Some aren't being used, and some are being used regularly. Okay, so this is a really good slide. This gives information about drug compliance and adherence in the elderly, and just gives you some straightforward ideas on how to make sure that someone is taking their medication regularly. I won't go through all the slides because I'm approaching my time that I'm trying to keep to with these modules. But go through them. I think they're useful to know. Okay, so Beer's criteria for potentially inappropriate medications for older patients. So really it's a guideline for healthcare professionals to really help older patients improve their own safety by trying to de-prescribe medications, by trying to remove medications that are unnecessary for them to take regularly, which is leading to their polypharmacy. It's leading to adverse effects, leading to all kinds of drug interactions, and it's just not beneficial for them from a benefit risk ratio point of view. So it's very helpful it can be very helpful in geriatric medicine. So it's really a list of medications that are potentially inappropriate, that have high risk of adverse effects. Consideration should be given to avoiding these medications or at least closely monitoring them. And the list is updated so that healthcare professionals and nurses are familiar with the list. I don't think you need to know the list, but as we go through pharmacology, it'll become obvious that there's certain medications that are just not appropriate for older people because they're too sedating, or they put the patient at risk for falls. So just keep it in mind as a concept. Okay, and here's just a sampling of some medications that are considered high risk in older patients. But this is by no means a complete list. This is just an example. So antihistamines. So we use antihistamines for allergic rashes. We use antihistamines for all kinds of allergic symptoms, such as runny nose, sneezing, um, so insect bites, allergic drug reactions. So these medications are very sedating. Diphenhydramine, that's Benadryl. Hydroxyzine, that's another antihistamine. Don't worry about all the different individual medications. We will discuss some of these as the course goes on. But just know that they're sedating. They cause confusion in old people, which leads to all kinds of bad events, including falls, hitting their head, having a broken hip. So antihistamines we're very careful with them in the elderly. Antipsychotic medications. So sometimes we use these for patients with behavioral disorders. They have some dementia, and at nighttime they get very agitated and noisy in the hospital. They're confused. And sometimes we'll use some of these medications to settle them down. Unfortunately, they cause confusion and sedation and leading to potential for bad falls. Um, so they're also recommended not to use, but it's tempting to use because of their sedating effects at nighttime. Benzodiazepines, this is a big group you're going to hear about. Lorazepam, oxazepam, diazepam. They're sedatives. We use them for sleeping pills, anxiety pills, withdrawing from alcohol to stop seizures. So they're very sedating to the brain. So they're used for all kinds of different conditions. But in older people, look at their effects. Again, confusion, depression if they're taken regularly. Older people that are taking these medications throughout the day and then maybe a pill at night often become confused and have falls. Remember that some of these patients may have been on these pills for years, and the strength of the pill hasn't changed. But what has changed? The age of the patient has changed. They have become 1 year older every year. And with that comes decreased metabolism of the drug, decreased excretion of the drug. So the same dose drug has much more effect on an older person. Digoxin is a medication we use to help cardiac pumping, cardiac contractility in older people. So it's very dependent on renal excretion. It's actually directly just excreted straight out into the urine. It's not even metabolized. So if you have weak kidneys, you're going to build up digoxin in your bloodstream, and you're going to become potentially dig toxic. And that's why we keep an eye on people's kidney function with their creatinine when they're on digoxin. Muscle relaxants. I'm sure you've seen them at the pharmacy. Cyclobenzaprine is actually Flexeril. There's a whole bunch of them. There's Robaxacet, all kinds of muscle relaxants. Very sedating to old people. If it's relaxing, if you're taking a pill that is being advertised to relax your muscles, can you imagine how it's relaxing an older person's brain and causing sedation? And another effect called anticholinergic effect. So anticholinergic is, you're going to see this a lot. I might as well just tell you now. It is blocking the parasympathetic system, which is acetylcholine. And acetylcholine in the brain is very important in terms of the wakefulness state. So being awake. So if a drug has a lot of anticholinergic side effects, sure, it's going to affect all kinds of organs in your body, but when we're talking about the brain, if it's anticholinergic, it's going to cause sedation, confusion that potentially can lead to falls and bad injuries. Okay, so 3 more high-risk drugs in the elderly. Let's see why. So non-steroidal anti-inflammatories, that's your aspirins, your ibuprofen, your naproxen. Why are they tough on an older person? Well, I think kind of earlier in the module, so non-steroidal anti-inflammatory drugs that are just used so commonly for arthritis and painful conditions and sore joints. Well, they increase blood pressure. They're toxic to your kidneys because they inhibit prostaglandins in the kidneys, and the kidneys are very dependent on prostaglandins for functioning. They aggravate heart failure. So if a patient has a weak heart or congestive heart failure, it will worsen their heart failure. Patients tend to retain fluid on these drugs, partly because the kidneys aren't filtering as well, because these drugs are nephrotoxic. And another big issue with these drugs is that they irritate the stomach, and they can lead to gastritis, which is inflammation of the stomach, and that can cause bleeding, or they can lead to an ulcer in the stomach, and the ulcer can bleed. So gastrointestinal bleeding. Okay. Opioid analgesics. So so meperidine is Demerol. We don't use that very much anymore because it had a lot of side effects. Morphine, commonly used. Oxycodone, commonly used. Hydromorphone, the brand name is Dilaudid. That's commonly used. So all these opioid analgesics basically have the similar effects, which is control the pain, and similar side effects. And when we're talking about an older patient, the side effects in the brain, sedation for sure, confusion, falling over, and they get severely constipated on these drugs. These drugs usually need to be used in combination with a sedative, a laxative, whether you're old or young. But just look at the effects of most of these drugs. Not all of them, but a lot of them you're going to see sedation, confusion, falls. And it's the effect of the drug on the older patient's brain. Blood thinners. So whether we're talking about warfarin, heparin, we'll get to these. Clopidogrel, which is a platelet inhibitor. Aspirin, not listed here, but that's another one. They all increase the risk of gastrointestinal bleeding. Um, Older patients have a thin stomach lining, paper thin when they're old, and these drugs can make them easily bleed from their stomach lining. And what about when they fall and hit their head? When an older patient falls and lands on their head when they're on a blood thinner, they're at risk of bleeding into the brain or bleeding around the brain on the inside. So all kinds of hematomas or hemorrhages within the brain because of the fall that they were at risk for because they're older and potentially on other drugs that are sedating, and also now they're on a blood thinner. Okay, I hope this helps.